Hello guys, welcome back to Clinically Clear. So today we'll be getting back into ENT. We'll be covering all the aspects of epistaxis. Now before we go into epistaxis, that is nosebleed, let's understand the blood supply of the nose. Now two main arteries supply the nose, that is the internal carotid artery and the external carotid artery. But obviously not them directly through their branches. First, let's look at the internal carotid artery. Now as we know, internal carotid artery has no branches in the neck. The first branch it goes once it enters the head is the ophthalmic artery, and the ophthalmic artery along with the optic nerve, it enters the orbit through the optic foramen. So once it enters the orbit through the optic foramen, it gives two branches which supplies the nose, that is the anterior ethmoidal artery and the posterior ethmoidal artery. The anterior ethmoidal artery, it see this medial wall of the orbit is known as lamina papyracea, no? So the anterior ethmoidal artery, it pierces the anterior ethmoidal foramen, whereas the posterior ethmoidal artery, it pierces the anterior ethmoidal artery pierces the anterior ethmoidal foramen, posterior ethmoidal artery, it pierces the posterior ethmoidal foramen, and then it enters into the lateral wall of the nose. So if I take this as the lacrimal crest in front, if I go 24 mm behind the lacrimal crest, I get the anterior ethmoidal foramen. I go 12 mm behind the anterior ethmoidal foramen, I get the posterior ethmoidal foramen. I go 6 mm behind the posterior ethmoidal foramen, I get the optic foramen. So 24 mm, 12 mm, and then 6 mm. Then there are two branches. The as I told, the ophthalmic artery, which is a branch of internal carotid artery, it gives rise to two branches: the anterior ethmoidal and posterior ethmoidal. And anterior ethmoidal artery, it supplies the lateral wall, then it passes through the ethmoidal sinus. It supplies the lateral wall and passes through the ethmoidal sinus and then supplies the septum. So when it passes through the ethmoidal sinus, it creates a notch. This notch is known as you can see here, you can see a tiny notch here. This notch is known as anterior ethmoidal notch, also known as nipple sign. So what happens is when the patient has ethmoidal sinusitis, because of all this opacity over here, because of all the debris, the fluid, this anterior ethmoidal notch or this nipple sign may not be seen. So what happens during FES? Let's say the patient injures this when I'm doing the functional endoscopic sinus surgery for this ethmoidal sinusitis. Let's say I injure this anterior ethmoidal artery, then what will happen? Immediately it'll start bleeding, it'll get retracted back into the orbit and causing a dangerous orbital hematoma. Blood starts accumulating in the orbit. So this dangerous orbital hematoma is an emergency because otherwise it can lead to blindness because of compression of the eyeball. So immediately you need to drain it, right? So what we do is we give a curvilinear incision near the medial canthus. This curvilinear incision near the medial canthus is known as Lynch's-Haworth incision, and then we drain the blood from the orbit, the blood that is accumulated, and then we ligate the anterior ethmoidal artery. How do we ligate the anterior ethmoidal artery? At the anterior ethmoidal foramen through the Lynch's incision. So we drain all the blood and then we ligate the anterior ethmoidal artery to prevent more blood from accumulating. So this is one thing about the anterior ethmoidal artery. Posterior ethmoidal artery, we know that it is the only artery that does not participate in the Kieselbach's plexus or the Little's area in the nasal septum. The nasal septum, antero-inferiorly, you have the Little's area or the Kieselbach's plexus, where you have anterior ethmoidal artery participating, greater palatine artery, sphenopalatine artery, septal branches of superior labial artery, but not the posterior ethmoidal artery. The posterior ethmoidal artery does not participate in it. So this is about internal carotid artery. Next, let's look at the external carotid artery. See, external carotid artery is actually the main blood supply to the nose. See, anterior ethmoidal artery and posterior ethmoidal artery, yes, they are from the internal carotid artery, but very less blood supply, mainly from the external carotid artery. Okay, now external carotid artery also two branches. You have the maxillary artery and then you have the facial artery. See, facial artery, it comes and gives two branches, superior labial artery, inferior labial artery. This superior labial artery, it gives rise to some septal branches that supplies the nasal septum. So septal branches of superior labial artery. This is from facial artery. Not that important. What's more important is maxillary artery. This is the main branch. So what happens? The external carotid artery, the external carotid artery, it comes up through the neck and then it enters the infratemporal fossa. In the infratemporal fossa, from there it goes through something known as pterygomaxillary fissure or sphenopalatine fissure to enter the pterygopalatine or sphenopalatine foramen. Now here we have the lateral view of the face, right? So here you have the maxillary sinus, and here you have the lateral pterygoid plate. So you have the lateral pterygoid plate, and then here you have the maxillary sinus. In between the maxillary sinus and the lateral pterygoid plate, you have a region. This region is known as sphenopalatine foramen. So what happens from the infratemporal fossa through the pterygomaxillary fissure? It enters into the pterygo. Just 1 second. I apologize for the inconvenience. So from the pterygopalatine fossa, it enters into the from the infratemporal fossa, the external carotid artery, through the pterygo, the maxillary artery. I mean, apologies. The external carotid artery in the infratemporal fossa gives rise to the maxillary artery, right? The maxillary artery through the pterygomaxillary fissure, it enters into the sphenopalatine foramen. Now, this sphenopalatine foramen, the anterior wall of the sphenopalatine foramen is the posterior wall of the maxillary sinus. The posterior wall of the sphenopalatine foramen is the lateral pterygoid plate. So in between the two, you have this sphenopalatine foramen. Then, so now the maxillary artery has entered the sphenopalatine foramen, and within the sphenopalatine foramen, the maxillary artery gives rise to two branches: the sphenopalatine artery and the greater palatine artery. The greater palatine artery, it dips down to supply the palate. It once again dips down to supply the palate. It supplies the palate and once again comes back up to supply the nose. So it supplies both the nose and the palate. The main artery is the sphenopalatine artery. The maxillary artery gives rise to the sphenopalatine artery, right? This is the artery of epistaxis. This is the most common artery that gets injured in all types of epistaxis. Maximum blood supply to the nose is from this sphenopalatine artery. So what happens? This sphenopalatine artery, from the sphenopalatine foramen, it enters into the lateral wall of the nose through this, from the sphenopalatine fossa. From the sphenopalatine fossa, it enters into the nose through the sphenopalatine foramen. It enters into the lateral wall of the nose and then it supplies the lateral wall of the nose. So that is about the external carotid artery blood supply. Then let's come to epistaxis. So as we know, nosebleed is epistaxis. Now the most common site of epistaxis is Little's area, which is also known as Kieselbach's plexus. It is an arterial plexus. So the most common site of epistaxis in everyone, in adults, in children, in old age, it is Little's area, Kieselbach's plexus, which is an arterial plexus located at the anterior-inferior end of the nasal septum. Then you have other sites of epistaxis. For example, venous epistaxis, where retrocolumella vein, just behind the columella in the nasal septum. Then behind the posterior turbinate, posterior to the inferior turbinate, not posterior turbinate, behind the inferior turbinate, there you have something known as Woodruff's plexus. These are all certain venous plexus where you can have venous epistaxis. So first classification is arterial epistaxis, venous epistaxis. Arterial epistaxis, most common site is Little's area, which has the arterial Kieselbach's plexus. It is the most common site of epistaxis in everyone, adults, children, whomever you take. Next, coming to another classification, anterior epistaxis or posterior epistaxis. See, anterior epistaxis means the blood is flowing out through the nose. Why is it flowing out through the nose? Because the site of epistaxis is anterior to the opening of the maxillary sinus. And which is the most common site? The Little's area. So that is why the blood flows out through the nose. Posterior epistaxis, the site of epistaxis is posterior to the opening of the maxillary sinus, and this site is difficult to localize. You cannot localize where posterior epistaxis is. We know it is posterior to the opening of the maxillary sinus, but we don't know exactly where. And here the blood flows more into the mouth and into the throat. So that is why the patient comes with some complaints like coffee ground vomitus. That is the vomit, they start vomiting blood or their sputum contains blood. So that is anterior epistaxis. And anterior epistaxis is of course more common where it comes out to the nose. Then children, it's more common in children, which could be the cause. The cause is trauma. So that is about anterior epistaxis. Posterior epistaxis is less common. It is more common. It is more common in adults. Spontaneous causes. And generally, anterior epistaxis is less dangerous, low volume bleeds, whereas posterior epistaxis, because it is due to systemic causes, spontaneous causes, and it's flowing into the nose and flowing into the mouth and the throat. It is generally high volume bleeds and it is more dangerous. So now let's come to the etiology of epistaxis. So you can have local causes of epistaxis, and you can have systemic causes. So first we have local cause. Local cause, idiopathic, we don't know the cause. That is actually the most common cause of epistaxis in adults. The most common cause of epistaxis in adults is idiopathic. Then you can have certain infections like sinusitis, rhinitis, some granulomatous infections in the nose, etc. Local infections. Then trauma. Trauma can be iatrogenic trauma due to human error during functional endoscopic sinus surgery, during diagnostic nasal endoscopy, during nasogastric tube. This is iatrogenic trauma. Then you can have non-iatrogenic trauma. Example, nose picking. Nose picking is actually the most common cause of epistaxis in children. So non-iatrogenic trauma. Then you can have tumors. Tumors like angiofibroma. In angiofibroma, you can have it's commonly seen in young males where they have recurrent epistaxis again and again and again. So let's say a young male comes with recurrent episodes of epistaxis, then you have to check for angiofibroma. Then some drugs like topical nasal steroids, topical nasal decongestants and steroids, what they do is they cause vasoconstriction, they cause drying, which causes crusting of this mucosa. So when you peel off those crusts, it injures the blood vessels leading to epistaxis. So what are the local causes? Idiopathic, most common in adults. Trauma can be iatrogenic or non-iatrogenic. Iatrogenic like FES, DNE, during FES, DNE, etc. Non-iatrogenic like nose picking, most common in children. Tumors like angiofibroma. Anatomical like deviated nasal septum spurs. Infections like sinusitis, rhinosinusitis, granulomatous, and drugs like topical steroids and nasal decongestants. Next, coming to systemic causes of epistaxis. Now, systemic causes of epistaxis, first of all, we have bleeding disorders. So, bleeding disorders can be disorders of primary hemostasis where where platelet plug formation is not taking place. Disorders of primary hemostasis. Something wrong with the platelets. Either it can be quantitative disorders where patient has thrombocytopenia, low platelet count. What could be the cause for this low platelet count? Decreased production of platelets. Seen in leukemia, aplastic anemia. In leukemia, what happens? All the malignant cells, they infiltrate the bone marrow, so platelets are not produced. In aplastic anemia, bone marrow suppression, platelets are not produced. Or because of increased destruction of platelets, like immune thrombocytopenic purpura or hypersplenism. So what happens here? There is increased sequestration of platelets, increased breakdown of platelets in the spleen. So this can cause reduced platelet count, leading to disorder of primary hemostasis, or it can be qualitative platelet disorders like von Willebrand disease, Glanzmann thrombasthenia, Bernard-Soulier syndrome, etc. Or it can be patient is on antiplatelet drugs like low dose aspirin. Low dose aspirin. So these are some reasons, antiplatelet drugs. Then the patient can also have disorders of secondary hemostasis. Whenever you think of secondary hemostasis, you'll immediately think of clot formation, something wrong with the clotting factors. For example, during patient has vitamin K deficiency, clotting factors are not maturing. Patient has liver disorders, clotting factors are not being produced. Patient has genetic disorders like hemophilia, where clotting factor 8 is not being produced. Patient is on anticoagulants, which is inhibiting the clotting factors like heparin and warfarin. So first systemic cause is bleeding disorders, where you have disorders of primary hemostasis and disorders of secondary hemostasis. Primary hemostasis meaning you have to think of platelets. Secondary hemostasis meaning you have to think of clotting factors. Then infections like dengue. Dengue, we know that platelet count reduces, and when platelet count reduces, it can lead to epistaxis, bleeding. Long-standing hypertension. Now, just sudden episode of hypertension is actually not a direct cause of epistaxis, but long-standing hypertension can make the blood vessels very, very fragile. Hypertensive vasculopathy. This can cause epistaxis, systemic cause of epistaxis. Then there's another special condition known as Osler-Weber syndrome, Osler-Weber-Rendu syndrome, or hereditary hemorrhagic telangiectasia. So in this, what happens? the patient has multiple telangiectasias in the visceral organs and the mucosa. What are telangiectasias? These are regions of dilated capillaries. As you can see here, the capillaries are dilated. So because of that, what happens? The patient has multiple episodes of epistaxis. Let's say the nasal mucosa has multiple telangiectasias. They keep bleeding again and again and again. Patient has multiple episodes of epistaxis, 18 to 20 episodes of epistaxis per month. So how do you treat this? First, you cauterize the telangiectasia. You can cauterize the telangiectasia to stop the bleeding. Then you can do something known as septonasal dermoplasty, where we do skin grafting. We put skin graft onto the telangiectasia to prevent the bleeding. Or in severe cases, we do something known as Young's operation, where we just close the nostrils, surgically close the nostrils and make the patient breathe through the mouth to prevent the drying effect of these telangiectasias. Because what happens when you have so many telangiectasias in the nose, because of the excessive airflow, it causes drying, and this causes bursting of these dilated capillaries burst, leading to bleeding. So this is about the four systemic causes: bleeding disorders, both primary and secondary, infections, long-standing hypertension, as well as Osler-Weber-Rendu syndrome or hereditary hemorrhagic telangiectasia. Now, let's come into the management of epistaxis. Now, you can have low volume bleeds, basically due to trauma and stuff like that, or you can have high volume bleeds, mainly due to systemic causes. So, when you have high volume bleeds, first thing you need to do is you have to always check the vitals and control the blood pressure. During epistaxis, if you have uncontrolled hypertension, it is very, very bad, lead to excessive blood loss. So you have to control the blood pressure. First thing you have to do is check blood pressure, control the blood pressure, check vitals. And because it is due to systemic causes, usually high volume bleeds, you have to take a detailed history to rule out stuff like hemophilia and stuff like that. Then maintain airway breathing circulation, and you have to keep an IV line ready, because in case the patient needs IV fluids or needs blood transfusion, stuff like that, you have to keep an IV line ready. But irrespective, after all that, both low volume bleeds and high volume bleeds, first thing you'll do is you'll make the patient go into Hippocratic's position or Trotter's position, where the patient leans forward slightly and closes the anterior nostrils, pinches the anterior nostrils to put pressure and reduce bleeding, to control the bleeding. Let's say Hippocratic's method or Trotter's method does not work. Next, we go to cautery. The bleeding continues. So, cautery, what do? We can either do chemical cautery, where we give topical silver nitrate drops, or we can do electric cautery in the form of bipolar cautery. Why we use bipolar cautery and not unipolar cautery? Because unipolar cautery, it sends the current deep into the tissues. It can damage the deeper structures. But bipolar cautery, it will pass between the two electrodes. Hence, we prefer bipolar cautery. Along with cautery, we always give topical decongestants. Why? Because they cause vasoconstriction and reducing the bleeding. So, Hippocratic's method, Trotter's method didn't work. We go to cautery plus nasal decongestant. Let's say cautery also doesn't work. The bleeding continues. Then we go into anterior nasal packing. Now, for anterior nasal packing, we can use something known as Bayonet's forceps. Here you can see. It looks like a bayonet. Bayonets are those long guns with swords attached on top. So they are guns with swords. So it appears like that, Bayonet's forceps. Then you have another one known as Tilly's nasal packing forceps. So what we do here is, in the olden days, we used to use ribbon gauze. Ribbon gauze coated with antibiotic ointment and paraffin jelly. So we used to pack the nose anteriorly, either in horizontal layers as given in this picture, or also in vertical layers. So both ways. But nowadays we prefer to use this Merocel gel foam. This Merocel gel foam, it comes like this. And once we place it in the nose and we add saline water, it absorbs the water and it puffs up, thereby applying pressure, packs the nose and reduces bleeding. So nowadays we commonly use Merocel gel foam for nasal packing. Let's say anterior nasal packing also you do. It does not work. The bleeding continues. Then what happens? We go for posterior nasal packing. Posterior nasal packing, we pack the posterior aspect of the nasal cavity and even the nasopharynx. So now, problem is patient is not able to breathe through the nose. So to maintain the airway, to keep the airway patent, we add a Foley's catheter. We add a Foley's catheter like this to maintain the airway so that the patient can still breathe, but the nose is packed. This is one thing. Another thing, we also commonly use something known as balloon packing nowadays. As you can see here, through the balloon you have the airway, and outside the airway you have two balloons. Here this packs it anteriorly and this packs it posteriorly. So simultaneous packing, very very efficient anterior and posterior balloon packing. One thing you need to remember is any sort of nasal packing, you have to admit the patient and start them on antibiotics immediately. Very, very important. You cannot do nasal packing and send them home. You have to admit the patient and start them on antibiotics. Let's say you do nasal packing and still the bleeding continues. Then what happens? You have to ligate the arteries. Now, the arterial ligation, you will do it in the order of hierarchy. Which did I tell is the artery of epistaxis, sphenopalatine artery. So, first one will ligate is sphenopalatine artery. And this surgery is known as TESPAL, transnasal endoscopic sphenopalatine artery ligation. So, what we do is we go endoscopically, we go to the sphenopalatine foramen located 1 centimeter behind the middle turbinate, and then we ligate the sphenopalatine artery. Let's say it still doesn't stop. Sphenopalatine artery is a branch of maxillary artery. So next we ligate the maxillary artery. Where do we ligate that? In the pterygopalatine fossa or the sphenopalatine fossa. So this will either do through Caldwell Luke approach, where we make a hole in the anterior maybe make a hole in the anterior wall of the maxillary sinus, go into the maxillary sinus, make a hole in the posterior wall of the maxillary sinus, and then enter the sphenopalatine fossa or the pterygopalatine fossa. So that is the that is how we ligate the maxillary artery. Let's say it still doesn't work. Then maxillary artery is a branch of external carotid artery. So you ligate the external carotid artery in the neck. And as I told, if the bleeding is because of anterior ethmoidal artery damage, you have to ligate only the anterior ethmoidal artery through the Lynch-Haworth incision, curvilinear incision at the medial canthus. Go 24 mm behind the lacrimal crest, you will find the anterior ethmoidal foramen and ligate the anterior ethmoidal artery. But never ever ligate the internal carotid artery. Why? Internal carotid artery supplies the brain. If you ligate that, rest in peace. So never ever ligate the internal carotid artery. You have to ligate only the anterior ethmoidal artery, not the internal carotid artery. So how do we manage it? First, Hippocratic method, Trotter's method, then go for cautery plus topical nasal decongestant, then go for anterior nasal packing, then go for posterior nasal packing. If that doesn't work, go for arterial ligation in the order of hierarchy. So first, TESPAL, sphenopalatine artery, then maxillary artery, then external carotid artery. Never ligate the internal carotid artery. That's it for epistaxis. I think I made a few mistakes here, like when I'm talking. Actually, this should be sphenopalatine fossa and this area, and this is the sphenopalatine foramen. So I apologize for that mistake. I'll be more careful next time. Thank you for watching.